He has been awarded several recognitions, and also, as I said, his areas of clinical and research interest is basically improving IVF success rates and laboratory troubleshooting, oocyte vitrification and oocyte banking, fertility preservation for cancer survivors and social egg freezing, optimization of embryo transfer techniques, OHSS-free IVF protocols, and so on and so forth. So, a lot of experience there. He's organized workshops and trainings for our colleagues from very many different countries, from Africa, and not only. So, he will be our speaker today. A little bit about housekeeping, please. If you have any questions, any comments, as the presentation progresses, please post them on the chat box. We'll get them at the end of the presentation and discussion, and we'll read them out and we will answer them. There will be questions also from the speaker for all of us, because this is for all of us, because we do interact with the patients who have challenges with infertility. And we may have different approaches, but it's sort of trying to see how we can get around these cases. Before we start our presentation today, I would like to, in a special way, to recognize Mr. Omar Salmalkar Maya. He's the Assistant General Manager, International Business, and also Ida Modama, who is the head of pharmaceutical and consumer health at Harley's Healthcare Solutions. So I would like to, without, as we keep on saying, without further ado, I would like to ask our guest speaker today, Dr. Kapedia, to take the mic, and the floor is yours. Dr. Kapedia, thank you.
Thank you, Doctor. Thank you for such a kind introduction. I really appreciate. And I thank Kenyan Society of OBGY for allowing me for this talk. So, as we are all here, we, as a gynecologist, we are dealing with infertility patients a day in, day out. Some of our participants must be a general gynecologist who are doing basic infertility practice. Some must be very much in advanced infertility practice like IVF and ART. So today I have tried a topic which is not very much touched a lot. So how oocyte quality, what about oocyte quality in different type of pathologies? How to improve oocyte quality, that is one part. The second part, for all the gynecologists, those who are doing basic infertility practice, we have incorporated the basic workup for infertility patients. And the third part is specifically for ART specialists, or to understand how we can optimize our culture conditions, our IVF lab part, so that with such type of oocytes, we can have a better outcome. So I'll try my best to justify the topic. So let us first understand little basics of oocyte quality. So when we are doing IVF, once we have OCCs, oocyte cumulus complex available, when we clean them in the hyaluronidase, what we see is such a picture. These are such a beautiful oocytes. A lot of you guys must have seen them, few might not have. So let me explain the outer covering. If you see, this is the oocyte, this is the outer covering. It is called zona pellucida. This is the cytoplasm of the oocyte. Here, if you see, there is a small polar body, that is first polar body. And the space here between the oocyte and the cytoplasm and the PV space, in between the zona is called the perivitellin space, PV space. So this is basically the structure of the oocyte. Now, how we define oocyte quality? Basically, there are two things. One is nuclear maturity. Oocyte can be either of GV stage, germinal vesicle. They are antral follicles. If you take out and try to see, there must be a germinal vesicle oocyte. They are having diploid chromosomes. Once the follicle is ready, it ruptures, and it is released from the ovary. It is usually metaphase to arrested oocyte, that is mature oocyte. So that maturation, there are two types of maturation. One is nuclear maturation. That means from diploid chromosomes, 46 chromosomes, now it has become 23, 22 plus X. The same way, the cytoplasmic maturity. The cytoplasm contains a lot of organelles like mitochondria, Golgi apparatus, protein stores. They all help for the maturity of the oocyte. So, clinically, oocyte quality cannot be fully judged by morphology alone, just by looking at it, but how it develops, like M2 rate, that how many eggs are mature once we fertilize, what is the fertilization rate once we develop them in our culture conditions, how many blastocysts are developed, and most importantly, the euploidy rate. That means after becoming an embryo or a blastocyst, how many embryos are euploid. Follicles of adequate size does not guarantee a competent oocyte. So a lot of time what we see is when we are doing COH, control ovarian hyperstimulation, when we have a nice follicle, when we trigger it, and sometimes we repeatedly fail. One of the reason can be that the oocyte quality, the maturity of the oocyte, we don't know. So adequate size of oocyte, adequate size of the follicle, we feel it's carrying the perfect oocyte, but it might not be the case. So what is actually inside the cytoplasm? There are a lot of mitochondria. Probably it carries the largest mitochondrial complement of any cell in the body. The mitochondria number, the mitochondrial DNA. These are all, they correlate with developmental competence of all the in different species. Now, let us go. What bad can happen to an oocyte? As we know, the basis of infertility or bad sperm, bad oocyte, it's oxidative stress and the reactive oxygen species. So, what is oxidative stress? We all are aware. It is imbalance between reactive oxygen species production and the antioxidant defense. Now, mitochondria, which are abundant in the oocyte, they are the primary source of ROS. Now, this excess ROS, they can damage mitochondrial DNA and they can disrupt spindle microtubules. Spindle means the nucleus of the oocyte. So oocyte itself creates disturbance in the spindle and then can increase the risk of aneuploidy. So when there is oxidative stress is more, that can cause aneuploidy. This oxidative stress is responsible in the aging oocyte, in the obese patients, in PMOS patients, in endometriosis patients, and the patients who are very much habitual of smoking. So declining mitochondrial copy number, they are consistently reporting with advanced maternal age. So as the age advances, the mitochondrial reserve is fixed. And as the age advances, it goes on decreasing. There are other metabolic insults, like we know in PMOS, previously it was PCOS. The hyperinsulinemia is the basic pathology or insulin resistant that directly stimulates ovarian androgen production and it can disrupt folliculogenesis. So we know that in PMOS patients, we see a lot of problem with ovulation. A lot of cycles are anovulatory. They usually have hyperandrogenism. What they do is they again causes disruption in steroidogenesis. So collectively, this metabolic insult, it make the follicular microenvironment hostile. Now, there are few, as we are embryologist and clinician, in an embryology lab, when we see the OCC, oocyte cumulus complex, we cannot comment on the oocyte quality. But when we repeatedly see the patients of PMOS, we see the patients of endometriosis, we see the patients of elderly patients whose oocytes when we see, what we see is different types of pathology or different type of morphology. So if we talk about PMOS, there is a strong evidence that there can be a follicular arrest during stimulation at antral stage, and there can be excessive antral follicles that we all of us know. There is again strong evidence that in granulosa cells there is altered steroidogenesis. And there is a moderate evidence that the mitochondrial content is low in PMOS patients, and that is responsible for the development of bad quality oocytes. So, in short, PMOS, hyperandrogenic environment, high ROS in the follicular fluid, that can cause spindle, that means nuclear disruption. And this all gives us a clue why the fertilization rate is sometimes low in PMOS patients and why the quality of the embryos is bad. So let me tell you, you have seen the normal oocytes. If you see, this is zona pellucida, this is oocyte cytoplasm, and this is PV space. You see a lot of debris-like structure in the PV space. This is typical of polycystic ovary or PMOS patients. Sometimes when it is severe PMOS and ovulated PMOS, these are the patients, high androgen, these are the patients when we encounter such type of oocytes. This case looks still reasonable. In some cases, what we have seen is there is excessive amount of debris in the perivitellin space, and the quality of the cytoplasm is bad. And we have seen a lot of patients who go on multiple failures, even after doing all type of efforts. The embryo development is sometimes bad. So PMOS is a very crucial condition, and if by chance we get such oocytes, it is really difficult for the patient. Now, if we talk about endometriosis, there is another entity very common. So, strong evidence suggests that the elevated inflammatory cytokines in the peritoneal environment, they are responsible for the bad quality. There is moderate evidence, it suggests that reduced oocyte number and mitochondrial abnormalities are reported. And we all of us know there is a strong evidence that whenever there is the endometrioma and it is being operated, the ovarian reserve goes down significantly. This was a lot debated topic in a lot of conferences, but ultimately we all know that it is always, we have to be very judicious whenever we are dealing with the endometrioma patients, because they, after surgery, they might end up with low AMH and low ovarian reserve. This is, let me tell you. So you have seen normal oocyte, you have seen PCOS oocytes. Can you see the difference between the zona, the color of the zona? It has started becoming brown. Unfortunately, this patient has a cytoplasm which is also bad, but you can see the zona. It is thick, the thickness is more, as well as the texture, and the color is also bad. This is probably due to endometrioma development in those follicles. This can create a lot of problems. These usually fertilize normally, embryos develop normally. These are the patients we always recommend when the zona is thick, you see under microscope, you should always go for laser assisted hedging for this type of patients. Because what happens ultimately when the embryo grows, the blastocyst has to come out of this zona and it has to come out and then implant in the endometrial cavity. So this is just what we can do. Otherwise, the embryo development is also bad with severe endometriosis. So follicular environment in endometriosis, it affects oocyte quality and thus embryo development. One more study in 2015, it says oocyte coming from minimal or mild endometriosis patients have decreased oocyte quality due to impaired mitochondrial structure and function. And also, one study done in 2013, it says that endometriomas seem to affect oocyte number and quality more than it affects endometrial receptivity. Now, nowadays, we know a lot of elderly patients come to our clinic. The late marriages, they go for their pregnancy late. So the mean age of patients trying pregnancy has increased. So the mean age of patients coming to the fertility expert has increased. Even the environmental factors, and there are a lot of other things which has decreased the ovarian reserve over time. So what advanced age causes? First is spindle assembly. We know oocyte carries the spindle. The most important part in the oocyte is the spindle, that is the nucleus. So the spindle assembly declines with age. There are misaligned chromosomes. Mitochondrial aging, it also affects ATP available. And that again causes separation of the chromosomes. So clinically, it causes rising aneuploidy rate. That's why elderly patients are difficult. Even if we have few oocytes, we are always very worried about aneuploidy. The left picture, if you see, this is the picture of immature oocytes. You can see the cumulus hair is very compact. The oocyte, the cytoplasm is very darkish. These are the immature oocytes sometimes we encounter. This is one more entity, oocytes with SER. You can see a small structure that is smooth endoplasmic reticulum. Whenever we encounter such type of patients, we know that this patient's outcome is not going to be so good. Now we have discussed a lot about the problems. Now, what about the remedy? It starts with lifestyle optimization. So weight reduction, if we go the modest weight reduction of around 5 to 10%, it has shown there is a strong evidence that it helps metabolically, and there is moderate evidence that improves the oocyte quality. So that is one way of improving oocyte quality in obese patients. Mediterranean pattern diet, that is supposed to be most healthy diet. So if we ask the patient to follow that, even there is moderate evidence that the outcome can improve. As all of us know, regular moderate exercise, the moderate evidence, it suggests that it helps in metabolic health and insulin sensitivity. And yes, it can help for the fertility prospects too. Smoking. There is a strong evidence that smoking, if the female patient is doing smoking, it is consistently associated with reduced oocyte yield. That means the number of the oocytes are less, the quality is bad, and the live birth rate is bad in such patients. And alcohol moderation, moderate evidence is there that there is negative association between alcohol consumption and the IVF outcome. So we should ask our patients to get rid of smoking and to contain their alcohol consumption. Now, after lifestyle modification, what are the molecules available in the market which can help us to improve the oocyte quality? Because you must be getting a lot of patients who are coming, who are just planning their family, and they come to you and say, Doctor, I want to, this is my age, 32, 33 years age. I am a smoker or I am having habit of alcohol. I want to conceive, but I know I have limited time. If you can help me to prescribe some medicines which can improve it. So there are certain molecules. Let us talk about coenzyme Q10. So basically, these are the antioxidant supplements. If coenzyme Q10 pre-treatment for 1 to 3 months, it supports mitochondrial electron transport. So there is a Cochrane meta-analysis. It suggests that there is possible improvement in clinical pregnancy, particularly in elderly patients. Melatonin, again, one of the strongest antioxidant. If it is given for a longer run, it can help to decrease the ROS production in follicular fluid, where the oocytes develop. And some RCTs have shown improved oocyte quality as well as embryo quality. N-acetylcysteine, we know all of us are using for the PMOS patients. It is basically a glutathione precursor, and glutathione again is a strong antioxidant. There is a moderate ovulation that it helps in ovulation, but there is a limited reference that the oocyte quality improves with N-acetylcysteine. The same way it is with vitamin D. There is a conflicting overall evidence. Vitamin E and vitamin C, we know they are antioxidants, but there is limited evidence that they help in the improving the oocyte quality. L-carnitine, there is a large RCT about its help, but yes, evidence is lacking in specifically in IVF patients. And omega-3 fatty acids, they have shown strong supportive molecule. So we have a lot of preparations available. These patients, we can prescribe to the patients, elderly patient, those patients are having severe PMOS, or those patients are having repeated implantation failure, or those patients who have tried few treatment cycles but they didn't conceive. These are the patients we can try. Though we have to tell the patients that most of the treatment or most of the molecules are empirical, we are helping. Now, if we go about Hormonal. There are few adjuncts we know, that is DHEA, that is dihydroepiandrosterone. It is the meta-analysis suggests that there is possible improvement in ongoing pregnancy rate. It is specifically used for peer responder patients. But yes, again, American guidelines suggest that there is insufficient evidence for its routine use. Growth hormone adjuvant therapy, it can also be used in poor responder patients. Myoinositol, dchironositol, again, we know we are using in PMOS patients. It improves insulin sensitivity and probably oocyte and embryo quality. For poor responder elderly patients, we go for androgen priming, transdermal testosterone, sometimes recombinant alloy supplementation. But these, it doesn't have confirmed effect about the quality, though it might help in increasing the oocyte yield. Nowadays, a lot of guys are using dual trigger, GnRH agonist plus HCG. It may improve oocyte maturity, but it doesn't do a lot with the oocyte quality. And metformin, again, we know it helps in improving insulin sensitivity. There is a strong evidence about its ovulatory benefit. It helps to make the patient ovulate, but there is moderate evidence for its direct oocyte quality. There are few new regenerative therapies they are in practice. A lot of guys are doing PRP using PRP injection, but there is no adequately powered RCT which can confirm that it can help the patients to improve the oocyte quality. In future, we are keeping in our eyes on stem cell based ovarian rejuvenation as well as mitochondrial replacement therapy. Now, all the IVF practicing doctors, they are using all these protocols: NRH antagonist, GnRH agonist, short protocol, flare-up protocol, double stimulation, mild stimulation. But no stimulation protocol have been convincingly shown to alter the intrinsic genetic quality of an individual oocyte. Protocol choice mainly affects oocyte number, synchrony, and safety. So we have to make understand that when the polycystic ovary patient is there, when endometriosis patient is there, we have to deal with whatever quality the oocytes are. There are very less chances that by just changing the protocol, we might have a great change in the quality of the oocyte. These are few of the references which we had gone through for this. So the first one we have covered what basically it is more on a molecular basis. The base for those slides were. Now we'll move toward more clinical aspect. Any patient comes to your clinic, what basic workup you want to do for those patients? So as all of us know, it starts with history taking, age. Age is one of the most important factor that decides whenever a patient comes to a clinic that whether this patient is going to conceive fast, what are going to be the chances, how we are going to deal with this patient. Menstrual history gives a lot of clue about the ovulation, whether the follicular phase is short or when the patient is ovulating. Obstetric history, again, very important. If the patient is having secondary infertility, there are chances, that there are chances the oocyte quality, the sperm quality, and probably the endometrium might be very normal. If there is history of any surgical intervention, now then you have to keep in mind the additions, probable disruption of the tube-organ relation. These are the things you have to keep it in mind, and past treatment history. Now we come to the examination. Transvaginal sonography is the gold standard. We can always go for abdominal sonography, but yes, transvaginal sonography gives you a great advantage over the transabdominal sonography. Basic hormonal investigation, very important to know the ovarian reserve. We used to do FSH, LH. Nowadays, EMH has taken place. But still, in the patients of polycystic PMOS, we always go for FSH LH to see the high LH whether the LH is high or not, and if it is high, how much high LH is there. And TSH and prolactin, we know it always helps in for the ovulation. Again, then we go for fallopian tube testing. Very important. We are routinely, all of us are doing HSG, hysterosalpingography. There are advantages, disadvantages. It is non-invasive. But again, the disadvantages, it can be giving you false positive results sometimes. You might have a blocked tube due to spasm, bilateral blocked tube, but that can be mere the spasm. So the ideal way is to hysterolaparoscopy. It is again, the disadvantage is it is invasive, but the advantage here is you can see the tube-ovarian relation, you can see the patency, tube-ovarian relation, as well as you can see the quality of the tubes. Ovulation study. Again, I would always say that it is one of the investigation. As soon as a young patient comes to a fertility clinic, you always have to go for ovulation study. You understand basic physiology. What is happening with this patient, whether she is ovulating, which day, what endometrium size is there once it ruptures, and how the endometrium, whether it develops to the secretory transformation happens or not. And the most important is semen analysis for the male. A detailed semen analysis including the count, motility, morphology, and nowadays, in some cases, we have DFI2, that is DNA fragmentation index. Now, if a patient is coming to your center, the patient is asking for the treatment. Now, the patient, how you decide whether you will go for a planned relation, you will go for IUI, or the patient will straight away go for IVF for ICSI. Age is the most important criteria. Whenever a patient comes to your end, in this time, there is no waiting game. You should have an aggressive approach. When the patient is elderly, more than 35 years of age, IVF is always a better option. And male infertility patients with low count, low motility, they should be targeted for IUI. Now, whenever we do, there are three important criteria for ovarian reserve, that is antral follicle count, AMH, and the age of the patient. Now there is a situation when low AFC and low AMH, like 1 or 2 picogram per ml, then the patient ideally should go for IVF. We always have a tendency to, try a lot of natural cycles and IUI with these patients. But we have to understand that if the AMH is 1, it is going to go below 0.4, 0.5, 0.2, then the chances of patient conceiving with her own oocyte, even with IVF, are going to be less. So this is very important for all the gynecologists. Whenever a patient comes, whenever you do basic investigation, you need to know when the patient is to be done IUI, which patient is to be referred for IVF. Now, there is a case when normal AFC, normal AMH, and male factor infertility is there. In these cases, IUI trial can be done. When AMH and AFC doesn't correlate, this is a tricky situation. A lot of time you see that the age is reasonable, the follicle count is reasonable, but AMH is showing very low. In this situation, we have to rely more on clinical aspect like AFC and age, and we can treat the patient. AMC is a very strong indicator, but it is very important that it should be done in a proper, good pathology laboratory because there are a lot of variations in its reporting. A good semen analysis plays a deciding role. Like oligospermia patients, number is less, but motility is good morphology. You can always try IUI. Now, very important thing I would like to convey is that IUI can be done 3 to 4 times. You should not go on keep doing it for longer time. Severe oligospermia patient, severe asthenospermia patient, teratospermia patient, or OATS patients, they are all the patients for IVF ICSI, or probably they are the patients for ICSI. So don't go and try to do IUI. Instead of helping, we are harming them more. And IUI should be discouraged in such patients. Now, sometimes you encounter endometriosis. Laparoscopy has been done. You see a lot of pelvic adhesions. There is IPID, hydrosalpinx is there, previous pelvic surgery like ovarian drilling, severe male factor infertility, tuberculous endometriosis. More or less, this patient tend to go towards IVF. So to conclude, keep time limit in your mind. Be aggressive in your treatment approach because no patient is going to stay with you for more than few months. Don't go on doing IUIs because you are not doing IVF. Refer to the your friend for whoever is doing IVF. Azoospermia patients, in which we can do donor IUI. Normal ovulatory woman with patent tubes and oligospermia or osteospermia patients, these are the ideal candidates for IUI. That too, not more than 3 to 4 times. If we go doing IUI more than 3 to 4 times, it might cause endometritis and you might hamper the endometrial development for the in future. Now we have gone through the second part, which is basics of infertility workup. Due to time constraint, I have to manage these three topics in one presentation. Now we are moving toward the third one: how embryologist deals with the poor oocyte quality. So there must be a lot of IVF specialists in this group as participants. Sometimes you always encounter that your embryologist is saying that the oocyte quality is poor and we are not able to help this patient. The embryo quality is poor. So let us see what is actually happening and what we can do. So let's move to the embryology lab and see what we can do. So IVF lab management is the ultimate answer. When oocytes are compromised, your lab's culture condition need to be the most optimum. If even it is a little bit of suboptimum conditions are there, then these patients are not going to have a better outcome. Very important, when any patient comes, even for the embryologist, it is very important to go through the file and see what was the previous cycle, how many oocytes were retrieved, what was the fertilization rate, what was the quality of the embryo. This gives them a clue. They are mentally prepared that what we are going to encounter, and accordingly they can act. It helps them to plan their protocols. Now we'll go for fewer points in embryology lab. Fertilization. When oocyte quality is bad in normal responder patients, what you do? IVF or ICSI. Normal responder patients, usually we do a half IVF, half ICSI. Poor responder elderly patients, when the oocyte yield is low, number of oocytes are less, usually we rely more on ICSI. Endometriosis patients, you can go for IVF or ICSI if the male factor is not there. Plus, it is always advisable if the zona thickening is there, you can do little laser assisted hatching. And sometimes we encounter previously fragile oocytes. They come under the category of poor quality oocytes only. And while doing injections, sometimes they get lysis. So in these patients, in the next cycle, either you can go for IVF or whenever whoever is doing ICSI, they should be a lot more cautious. Now there is a myth that blastocyst transfer. You culture the embryos till day 5, and these are the only embryos which you give you good pregnancy rate. Now, blastocyst culture is very subject to the patient. It depends or varies from patient to patient. If you have good number of oocytes, or sorry, good number of embryos, day 3 embryos, and good quality embryos, day 3, 8 cell embryos are there, they are the best suited patients whom you can do blastocyst culture. Sometimes poor responder patients, elderly patients, when you have hardly 2 or 3 oocytes, you have 1 or 2 embryos which have developed, you can always transfer on day 2 or day 3 and you can get the results. It is not always necessary to take them to till blastocyst and then to transfer. When we are transferring day 2 or day 3 into the uterine cavity, actually we are putting them in a better environment than the incubator. So it is very fair. Poor responder patients, elderly patients, you can go for day 3 transfers. Nowadays, we have a lot of centers doing trophectomy biopsy and PGTA for them. So repeated implantation failure patients with good quality endometrium, you always feel that there must be something wrong with the embryo. In that case, you can do PGT, that is pre-implantation genetic testing for aneuploidy. Though it is very debatable with elderly and poor responder patients, because in these patients, the number of oocytes are less. So when you are going for a blastocyst culture, usually nowadays we go only for trophectomy biopsy on day 5. So whether to culture them till blastocyst, and sometimes if you don't have a blastocyst on day 5, leave that biopsy, but even you don't have embryos to transfer. So it's again a very debatable question. Now, there are a lot of gynecologists who are really interested to go for IVF lab setup. Let me tell you one golden line, which is the best thing or which is the heart of the IVF lab. That is the incubator. Your incubator should be of the best quality, irrespective of its price. There are a lot of variations available, like box type incubator, big incubators, and bench top incubators. There are CO2 incubators versus triple gas incubators. There are pre-mixed triple gas. In triple gas, there are two types: pre-mixed triple gas, which contains nitrogen, CO2, and oxygen, and there are the triple gas incubators in which you have to join the cylinders of nitrogen and CO2, and they have their own mixture which mixes all three gases. There are dry incubators, humidified incubators. So most of the times embryologists take this call that, okay, this is a good incubator. But being a clinician, when you are investing, when the patients belongs to you, it is your responsibility to look into it. You should know that which incubator is better, and you can always discuss. If you have a knowledge, you can always discuss with the your embryologist and for the benefit of the patient. This itself, incubator, is my one topic of discussion, but yes, we are going not going to go in lot detail. If you see, these are the two various types of. The left one is a triple gas incubator where we have CO2 and nitrogen separately attached. And the right side is a incubator where there is a premixed gas in the cylinder and which straight away comes to the incubator. Now, bad quality oocyte you are dealing with in your IVF lab, you have to be optimal. So check your temperature, check your heating rates, check your laminar flow workstations, check pH of all pre-gas media. pH has to be checked by ABG machine, not the conventional old machines. ABG machine, arterial blood gas analyzer, gives you the perfect reading. And the pH should be between 7.2 to 7.4 for all the media. After having good protocols, after having the best recombinant hormone, after doing all your pickup procedure, embryology procedure, everything good, you have a standard state-of-the-art lab. Now the judgment day comes. That is the embryo transfer day. I always say the real embryo transfer, the real art in ART is embryo transfer. Embryo loading technique, how much volume to be loaded, where to position it in the endometrial cavity. It has to be done always under USG guidance. Trial it is must. There are a lot. I have already done one whole day seminar for this embryo transfer. So it's a huge topic and we should all go in detail and optimize it at its best. So what ultimately we want, whether it is Oocyte, because we are all optimistic, we are IVF specialists, we are embryologists, we always think positive. This is what we expect on day 2, day 3. These are 4-cell embryos. Again, you can see here, these are 8-cell day 3 embryos. This is nice morula, compacted morula, and these are the beautiful day 5 embryos, which we are expecting on day 5. So ultimately, aim in hand is starting from day 1 to go for till day 5. And if not possible in all the patients, at least we can transfer on day 3 too. So this is all about the 3 parts of my talk. I have tried to justify. I have tried my best. I would invite Doctor to please start the rapid fire question for all the participants. Hello.
Hello, can you hear me now? Yeah.
Yes, Doctor.
Yes.
Please go
Thank you.
ahead, sir. I'll
Thank you.
I'll
Thank
go
you.
for the next question, please.
Yes, we'll hold on with the questions for a minute. We'll come to them shortly. Thank you for the presentation and thank you for giving us a bird's eye view, basically about infertility, how to deal with it, and also the problems that we actually don't see upfront in the office, but which you encounter in the lab and under microscope. The type of eggs that you see, the quality, and of course, not forgetting the quality of the sperms and so on. And the other things that actually do contribute hugely to the success of the treatment, because ultimately, at the end of the day, we want these couples who've been struggling for many years to have a baby, or to have babies for that matter, and that they can go home safely and enjoy their families. There are a couple of questions on the chat box. Please, if you have any questions, any comments, please post them. I would like to ask a representative from Harleys to do a quick presentation, and then we'll come to the questions. And I can see there are quite a number of very interesting questions which we are coming back to. So, Harleys, you have a few minutes for presentation, and then we'll come to the questions. Thank you.
All right, Dr. Please confirm if you can hear me.
Yes, we can
Yes.
hear you. We can see your presentation. Please go ahead.
All right. Thank you so much, and good evening, colleagues. This evening, I'm Libert Bethwell, medical training manager coming from Harleys. And Harleys, as Harleys, we are committed, and you're still committed to bring you the best high quality solutions that are fit for your patients. And today's session has been sponsored by MEA, which is one of the companies that distributes and market their products through Harleys. And specifically tied to the presentation of the day, I would like quickly in the next few minutes to highlight one of the products that is relevant to our discussion, and that is Overcare Myo. When you talk about Overcare Myo, this is a product that is used in the treatment of female infertility. And it is a unique and powerful formulation that comes with 18 essential micronutrients that handles or tackles multiple infertility contributing factors. I'll highlight some of the ingredients shortly, but before I do that, when you talk about infertility, oocyte quality matters, and it does so greatly. And as we well know, oocyte quality is a major determinant of number one, fertilization rates, embryo quality, implantation success, and live birth outcomes, especially in women who have polyendocrine metabolic ovarian syndrome, women who have insulin resistance, hormonal imbalance, advanced reproductive age, and also recurrent IVF failure. And oocytes are often affected by a couple of things, key among them impaired insulin signaling, also oxidative stress, altered follicular microenvironment, and also micronutrient deficiencies. And that's where Overcare Myo comes in. And I'll just give a brief about this particular product. It comes in a combi pack, and each combi pack contains two tablets. We have what we call Formula A tablet and Formula B tablet. Formula A tablet primarily has myo-inositol, that is 1,000 milligram, and then Formula B tablets has a couple of minerals as highlighted on your screen. And each of them has a specific role that it plays, but I'll highlight a few of them that are relevant to this particular discussion. Now, when you talk about determination of oocyte quality, a couple of things. Number one, you talk about insulin signaling and ovarian function, and the ingredient or component of Overcare Myo that plays that critical role is myo-inositol. When you talk about follicular maturation, also myo-inositol plays a critical role. Hormonal regulation, we have vitamin B6 that is in 15 milligrams, and also zinc that is in 15 milligrams in Overcare Myo. When you talk about folate status, that affect oocyte quality or determines oocyte quality, we have L-methylfolate that is found in 500 micrograms, and also folic acid that is found in 1,000 microgram. On cellular division, we have vitamin D3 that is found in 50 microgram, and also vitamin B12 that is found in 30 microgram. We talk about oxidative stress protection, which also determines the oocyte quality. We have selenium as sodium selenate that is found in 100 microgram and beta carotene in 3 milligram. And lastly, we talk about endometrial and ovarian perfusion. We talk about L-arginine that is found in Overcare Mayo in 10 milligram. As you well know, L-arginine is a precursor of nitric oxide, which is a vasodilator that ensures the endometrium and also the ovaries are well perfused. Now, if you prescribe a dose that is one formula A and one formula B daily, then this is how you're supposed to advise the patient to take the product. They can take the product at the same time, preferably after meal. But if you're prescribing two formula A tablets and two formula B tablets daily, either the patient can take all 4 tablets together after a meal if the dose is tolerated, or you can split them into formula A, one formula A tablet and one formula B tablet in the morning, and the same in the evening if that is more comfortable to the patient. Lastly, allow me quickly highlight the other ranges that we have under Overcare range. Apart from Overcare Mayo, as you can see on the screen, we also have Overcare, which is a critical product when it comes to general female reproductive health and basic preconception support in women who are having irregular cycles, and can be used as a nutritional adjuvant during fertility workup. Also, we have Overcare Forte, which is used or can be recommended to be used in oxidative stress mediated subfertility, where we have cases of poor oocyte or embryo quality and also unexplained infertility, and as an ovulation, induction, or in assisted reproductive technique or technology adjunct, and also as a secondary fit in cases where we have polyendocrine metabolic ovarian syndrome, where the oxidative stress phenotype dominates. That's how the products look like, the 3 products that fall under Overcare range. And that is my presentation. Over to you, Dr. Kireki.
Thank you very much, Dr. Bethwell, for that presentation of the range of your products. I'm sure most of our patients will benefit from them. So I go to the chat box and quite a bit of action there. And I said, please type your questions. I saw Dr. Ogweno's question. Only it has disappeared. I don't know if they canceled it. Basically, a very interesting question about mitochondria. We all know, I think, from medical school that cells have a lot of mitochondria, but we were never. I don't think I can remember. We were told it's about 100 to 600,000 mitochondria, which is an amazing number. If you consider there are several billion cells in our body, so you can imagine the number of mitochondria that we have in the body. So the question that Dr. Bueno asked is mitochondrial treatment. I know there was a baby, I think it was the first baby in the world in the UK some time ago, and because it had never been done before, Parliament had to approve for the baby to have mitochondria to be switched from the mother and get fresh mitochondria from a donor. So the question Dr. Bueno asked is, what do you think about mitochondrial treatment in IVF, and more so in the developing world?
It's a hello. Am I
Yeah,
audible?
go ahead.
Okay. So basically, it is a 3-party reproduction. So the oocytes, the basic problem dealing with mitochondrial transfer is we cannot transfer the mitochondria. We have to transfer the nucleus. So we have to have the surrogate oocyte, which is having good mitochondrial content. The oocyte spindle has to be removed, and the patient's the spindle has to be transferred there, and then the fertilization has to happen. Nuclear transfer itself has a lot of ethical issues, a lot of legal issues in different countries. So, I mean, in recent time, I mean, I don't see, I mean, it's, practical help in our day-to-day practice.
Okay, thank you. I hope, Dr. Ogweno, you've got that answer. Professor Wanyoro, great presentation, quite insightful. And then we have a question again about transfers. You mentioned a little bit about the PGTA, and the Faith Wangoy asks, would you recommend to transfer a high-level mosaic embryo if it were the only option remaining after PGTA?
Okay,
Remembering
this
that there can
is
be self-correction of the embryo again after transfer.
yes, yes, yes. So, I mean, yes, it's again a very debatable question. There is no single answer to this. It is again very subjective. We have discussed in a lot of places, but yes, it all depends on the, patient cycle, whether they had previous history of miscarriage, whatever. There are strong previous history, then we would not try to transfer because then the patients are very anxious. The patients where we can take little chance, we can counsel them, and if they are ready to, face that situation, then yes, probably we can try to transfer. It's again a very debatable question.
So it's a strong ethical, moral issue which we have to deal with. And as we know,
Yes,
this field is basically has a lot of ethical, moral landmines which you have to deal with on an everyday basis.
exactly.
Great presentation, Dr. Dharmesh. A special thanks to Dr. Kireki, who has been a great, Omkar. Thank you. And the best moderator. Another one, Master Solomon. Thank you very much, Dr. Dharmesh. Very informative. Many thanks for excellent presentation. Are there natural dietary interventions that improve oocyte quality? Any natural ones? We talked about coenzyme Q10, we talked about melatonin, we talked about DHEA, etc. Some other people also talk about evening primrose, and so on. Are there any natural ones to the best of your knowledge?
I mean, I'm not sure about this. I'm sorry. I won't be able to answer this. No, I don't have any idea about that yet.
To the best of my knowledge, some people have suggested to use evening primrose, that it may have an impact. But then when you go to the studies, you actually don't find anything really substantive that can actually direct us in that direction, in that way, that we can try evening primrose and so on. And there's something else which has escaped my memory at the moment, which has also been tried. But I think all of them, it's basically that hype. I remember in the UK, there was a lady who had a placenta room. So she would actually take these patients there, and it was a red room and with the pulsations. Apparently, this was supposed to rewire the brain, as it were. And these ladies would imagine there is a baby in the womb, and because of that pulsations, quote unquote, would make it a lot better for the embryos to implant. Some of these things, again, as I said, ethically moral, is a lot of challenges. So that about the natural products, we also don't know. And we also do get, especially in my practice, and I'm sure some of my colleagues who've been in this space for some time, we do get patients, couples who have had challenges with infertility for a long time. And you see the first 2-3 years, well, there may not be any challenges, but then later on, you find the auntie or the grandmother gives a concoction, a herbal concoction, and say, go and take a cup of this or a glass of this. First of all, we don't know what is in that concoction. We don't know the chemical structure. We don't know how it interacts with other medications, if any. And we don't know how it even is supposed to help you. So the herbal things, we should be a little bit careful about that, even though anything natural, anything herbal is not supposed to affect our bodies and our chances of, success. But we should be careful because we have actually no idea about anything. It's just that, oh, somebody used it and it helped her, or somebody used it and it helped him. Jitanjali Patil, great presentation. Any role of growth hormone injections along with stimulation for poor ovarian response. And maybe I can add a little twist to that. If you were to use the growth hormones, how long would you use it? Would you use it before? Would you use it during the stimulation? And what strength maybe would you use it from? Would you start it during right at the beginning, or would you start it as cetrorelix, antagonist, somewhere around day 6, day 7, and for how long?
Doctor, as we said, being an primary and embryologist and clinician, I have or we have seen over the years that whether it's a poor responder patient or whether it is elderly patient, when the oocyte yield is low, we have a very different strategy to deal with. What we believe is by doing all sort of things, we can improve the number of the oocytes. But what matters the most is the quality of the oocyte, which we have talked about the aneuploidy of the oocyte, about the their developmental competence. Whenever such patients are there, we always go for IVF elderly patients. Very rarely we go for growth hormone treatment. Yes, sometimes we use transdermal progesterone treatment, but being in India, we don't routinely recommend to all the patients, and there is no definitive, proven role for it in helping the improving the number of oocytes as well as improving the quality of those oocytes. So we are uh, not in favor a lot of adjuvants. If it would have been easier, like taking the tablets, it is okay. But anyway, the patients are under stress. They are taking a lot of injections. They are paying a lot. We are not having the, insurance covering the IVF in India. So it's a very difficult scenario. We have to manage it within the limits of patient's pocket. So very rarely we go for, any adjuvants for this, like specifically if we are talking about the growth hormone.
Thank you. I think now we can go to the questions which you had prepared for us. So, ladies and
Yes.
gentlemen, the teacher has a few questions for us, which I will read, and then you can send in your answers maybe in the chat box. We see what your thoughts are. This is basically going to be an interactive session. Please go ahead, Dr. Kapedia, with the question. The first question.
Can you see the slide? Can you see the slide, doctor?
No, I can see your picture. I can see you, but I can't see the slide yet.
Okay. Just give me 1 second.
No problem. Please go ahead.
Share करना slides. Share करवाना slides.
Okay, maybe as we are waiting for the questions to come on, maybe 1 or 2 questions about alcohol. You mentioned about alcohol in moderation. Moderation is a very amorphous term. What exactly is moderation? Because for some people, well, a bottle of Johnny Walker may be moderation, and others maybe a glass.
that is, doctor, that's very subjective. Let me tell you. That's a very good question. Ideally, but yes, even if we say at least they can decrease whatever. Moderation means it has to be, in accordance to what is their intake. I mean,
Okay.
if they can decrease it, otherwise we know it's very difficult it is very easy to say, but very
Yes.
difficult for them. Okay, so I think, doctor, we have a first
Okay.
question. If you can.
So we have the first question there. Female age 35 years, AMH 0.8. I think this is in nanograms per milliliter. Trying to conceive for 3 years. Choice of treatment, IUI, IVF, ovulation and study and planned I can see Faith Wangoi has come up very quickly there. Professor Wanyoro also has followed with IVF. Dr. Ramadan, another IVF. Any other takers? Dr. Ogweno, Dr. Makabe, all of them are IVF. We have very good students here, Dr. Kapadia. I
Yes,
think
they are all
you've done
good.
a fantastic job. Esther Kelo, also IVF. Fantastic.
That's great. That's
And I
great. So
think,
they don't want to waste time of the patient by
no,
doing the other procedures.
absolutely.
Yeah.
James Injiro, also IVF. And I think this dovetails very, very nicely with what you mentioned about IUI and not to waste time.
Exactly.
Three times, you mentioned that three times, but what you did not tell us is about age. Age. Yes, Dr. Bueno, is just a question or a poll. It's just a question. We don't have a polling mechanism. Just send your answers, IVF or whichever answer you think is appropriate. So, if does age factor also come in the number of IUI cycles that you can do, Dr. Kapadia, as we
Yes,
go to the next question? Yes.
yes, certainly. With age,
Mhm.
the ovarian reserve is going to go down. That is for sure.
Yes. Yes.
So it is rather a different scenario. Even if the
Mm.
patient is young, even if the
Yes.
patient's age is less but AMH is low, even if
Mm.
the patient is like 25 years of age and the patient AMH is zero point 0.8, we see a lot of
Mm.
patients, such patients. Still, the answer has to be the same. It has to be
Mm.
IVF.
All right. All right. Thank you. Thank you very much. The next question, please. So there we go. Semen reports is a count of 2 million. You have a motility of 80%, and we have a morphology of 20%, which is normal. We need 4% or more. And the female is normal. So do we go for IUI, IVF, ICSI, or planned? I think relation is basically to have intercourse, as it were.
True, true, true.
Anthony Wanyoro, Ruth Ocheng, IUI. Duncan Madeka, IUI. Ogweno says IVF stroke IUI. John Karanja, IVF. So what Ogweno George says ICSI. Yes, there we go. So we have Dr. Ramadani says IUI, Dr. Esther Kilo IUI. So do you mind, teacher, because you are our teacher today, do you mind now, is that post-wash? That's a very good question Faith Wangoi is asking. Is that post-wash? Let's say it is
Yes, no, it
post-wash.
is not. Okay, what I have capped is without, I mean, it's a raw semen, which we
Yes.
have, when we see the first count, it is 2 million per ml. It is not post-wash.
Kathy Adul, ICSI. Yes. Maybe now you can clear the air. There. What do you do? Do you do IUI or do you do IVF? And if you do IVF, you do ICSI. What would your suggestion be?
Okay,
You
so
haven't been
this is
IUI.
little tricky. Yeah, this is little tricky situation again, tricky
Yes,
patient because
yes.
the count is very low, 2
Mm.
million. If we go by the count only, then the patient is straight away for ICSI.
Mm-hmm.
If we go, the good part here is motility. I have kept it as 80%. That means the motility is good. So hopefully the
Mm.
forward progressive motility will be good. So
Mm.
this patient can be tried for IUI. Now,
Mm.
if the patient female is normal, if the patient is little, the age is not too elderly, this patient
Mm-hmm.
can be tried for 1 or 2 cycles or probably maximum 3 cycles of IUI
Mm-hmm.
and then straight away ICSI. So
Mm-hmm.
female factor also will, female age specifically, let me tell you, will come in the picture.
Mm-hmm.
But yes, 2
Yeah.
million, 80%, you can try. But the most
Yes.
important part here is counseling. When our treatment is always having the results in percentage, we need to
Mm-hmm.
talk to the patient. Sometimes patients are not ready to try for IUI. Okay,
Yes.
they say no, the count is 2 million and we
Mm.
want to go for ICSI only. Yes, then
Mm.
it is fine. They should be knowing the pros and cons of both the procedures as well as the results with the both the procedures. The patient might have done a lot of IUIs previously. The patient
Yes.
comes fresh to you. So like 3 or 4 failures, and then again you tell them, because you are not doing IVF practicing, you are not IVF practicing clinician, there is a natural tendency you will tell the patient that IUI can be done. So in that case, it is not true. You should be sending the patients to ICSI. But max to max, maybe if patient is willing to do, we can go for 2 or 3 IUI, that to max. If you tell me straight away, if that patient comes to me, I might not, if the patient is around 30, 32 or 30 plus, I will ask the patient to go for IVF ICSI straight away.
There is a maxim that says that the nearer normal the sperm sample is, the higher the chances of getting a good quality embryo and consequently a pregnancy. Look at the count. It's 2 million. I'm not very sure. Here you said count 2 million per milliliter. So it sounds more to me like concentration, but be it as it may that this is a count. Would you consider giving this gentleman some supplements before you take the next step? Just because of that count, even though the other parameters are okay.
The good part here is the morphology is good too. Routinely, all the patients which come to us, we always put them in some sort of medical, the male fertility adjuvants, which can help them. So we will always start the treatment. Most of the times nowadays, patients, they don't straight away come to the IVF clinician. They come after going to the gynec. They take few months of treatment and then they come. So they are usually on this medications for at least 2 to 3 months when they come to you. If not, yes, I would try. But let me tell you one more thing.
Yes.
Again, these are all adjuvants. They don't have definitive role. We have to keep it in mind. We cannot give them false hopes that by taking this, you are going to have 20 million per ml, or you are going to have, I mean, morphology is anyway good. So what I tell, it is again, it is an adjuvant. We cannot rely on not solely. We can start the treatments after 1 or 2 months of this treatment, and then straight away go for your whatever procedure you opt for, whether it is IUI or whether it is ICSI.
Thank you very much. What is the cutoff age for IVF in Ahmedabad? This is from Dr. George Ogwena.
Cutoff age is 50 years for female. So if the female is 50 years, we cannot go beyond 50 years of age for any female. And the male partner's age should be less than 55 years.
Less than 55 years.
Yes.
Okay. Is that only in Ahmedabad? What about in other states? Do you have different laws
No.
for every state?
No. It is the central law. It is the law for India. It is this, yes, for the whole India. It is ART Regulation Act and Surrogacy Regulation Act.
Okay.
The 2 acts, they have been implemented.
Okay. So question number 3, please, Dr. Kapedia, if you don't mind. As we are thinking about that, sometimes we meet patients who smoke shisha. I don't know whether you have shisha in India. What is your advice to them? Do you smoke? No, I don't smoke, but I smoke shisha. Once a weekend. With the girls out and so on. What are your thoughts about it? As we go to the third question. In question 3, in the case of bilateral hydrosalpinx, is it advisable to go for salpingectomy before embryo transfer? Salpingectomy, not salpingostomy. Yes, no, not sure. Again, let's hear what your thoughts are, ladies and gentlemen. Dr. Fade, you are the first on the other ones. What is happening? Lillian Onwonga says yes. No, these are, I think, the past ones. Salpingectomy. Okay, I can see Dr. Ogweno salpingectomy, Zara salpingectomy. Gitangil Patil says yes, even clipping of tube can be done. Antoinette Akeyo says no, don't do salpingectomy, so just do a transfer. Lilian Onwonga says yes. Esther Kelo says yes. Dibenzi says yes. Lilian Onwonga says yes. Yes. What is your answer, teacher?
Yes, when there is a case of, oh, yes, please.
Mm.
Okay,
Yes.
so when there is a case of bilateral hydrosulfings and when you are going for IVF, you have embryos prepared. We will always go for, okay, if it is, there are two ways. If it is
Mm.
sonographically evident that bilateral hydrosulfings is there, or probably on diagnostic
Mm.
laparoscopy, you have seen that, and the patient is to undergo. This is
Mm.
again, you have to counsel the patient beforehand because
Mm.
by doing salpingectomy, you are practically removing their chances of getting natural pregnant. The patient will always feel that okay, my tubes are being removed, but they should be counseled that there is these tubes are bad, already infected, already there is a fluid in that, so its patency might be or might not be, but the potency must have must have been lost. So these
Mm.
patients, ideally, if it is in our setup, we will go for salpingectomy after proper counseling of the patient. Only in the condition when patient is not ready to undergo salpingectomy, we will
Mhm.
go after due counseling for the embryo
Mhm.
transfer.
Mhm. Okay. So, what about there was an answer? What about salpingostomy, clipping the tubes? What are your thoughts about it?
You can always go for that, but yes, I mean, again, by doing clipping, what is the difference between not doing the salpingectomy? It is just almost the same thing what we
Mm.
are doing. It is just for the patients,
Mm.
psychological benefit that yes, the tubes are there, they are
Mm.
just clipped, not been removed.
Okay. All right. So, I think I agree with you. I would remove the tubes before doing the transfer. Question number 4, please. For PMOS patient, do you prefer to do FSH, LH with AMH? Yes, no, or none of the above? Any takers? FSH, LH with MH in PMOs, or former called PCOS. Faith Wangoi says no. Dr. Jitanjali Patil says yes. So there is a tie there. There's a yes and no. Dr. Bueno says AMH. And Dr. Lillian Onwonga says no. Any other takers? No takers. Sarah Kamau says yes. So yes, what are your thoughts? John Omedo, Dr. Bakadia said yes in the session. Maureen Okano says yes. Yes. What is your answer?
So these are the patients previously FSH and LH was basically used to know the ovarian reserve. What will be their status of the ovary? How much capacity of them to produce the oocytes? Now, once AMH has come, routinely we don't do with all the patients. But with
Mm.
PMOS patients, when we have, there is a high chances that the patient might have high baseline LH. So
Mm.
these are the patients we go for FSH-LH along with AMH, not for the reserve purpose, but just to
Mm.
understand what is the basic LH status. When
Mm.
sometimes it is too high,
Mm.
then we know that the prognosis of the oocyte, again, we come to our topic that the chances that are that the patient might have little difficulty in conceiving, maybe due to high LH, and maybe due to that might affect the quality of the oocyte. So we always
Mm.
do that, check the
Mm.
LH, FSH,
Mm.
the ratio, and AMH we may do, we may not do, because we know there are always a multiple follicles with the PMOS patients. So yes, we
Mm.
do. My answer would be yes.
Okay. Michael Karume also said yes, and Leonard Munania said yes as well. So the last question, I think there was a last question, Dr. Kapadia.
Yes. Yeah. Next
Mhm.
question is last.
So this one is quite interesting. 2 cycles of unruptured follicle syndrome in controlled ovarian hyperstimulation for IUI. This cycle, 2 follicles got to 20 millimeters average size. Beautiful endometrium there, 9 millimeters with a triple layer, triple lines. What will you do? Will you increase HSG units for trigger? Will you try GnRH agonist trigger? Will you go for dual trigger, where you have an agonist and you have HCG? Excuse me. Let's hear your thoughts. I can see Dr. Mogeni has just joined as a guest. Karibu sana, Dr. Mogeni. So GP says increase HCG units for trigger. Remember, there are 2 follicles, all right? 20 millimeters. Any other suggestion? Any other thoughts? Remember, 2 cycles of unruptured follicle syndrome, and you've been doing controlled ovarian hyperstimulation with the name of doing IUI. You've only got one answer there. Yes, Dr. Kapedia, what would you advise us to do in such a case?
Routinely, we are prescribing 10,000 units of HCG for IUI trigger. So in that case, I won't be going for increasing in the units of HCG. You can try GnRH agonist as a separate trigger only, but yes, then the problem will be luteal phase deficiency. So I will always try to go with a dual trigger, and that is really working very well for us. We have seen a lot of patients having unruptured follicle in previously in IUI, then we can go for dual trigger. The only condition is the 2 follicle, because there are only 2 follicles, we can take a chance. If by chance they are more than 2, 3 or 4 follicles, then again we can go with GnRH agonist trigger, and we have to give a lot of luteal support in such patients. Though the chances of pregnancy will be less because we won't be helping the luteal phase with the HCG. So my answer would be we will go for the dual trigger in this patient.
Wow, quite a bit there. Well, I normally use 5,000 to trigger if it is 1 follicle, but in this case, I think I totally agree with you. If there are 2 cycles of unruptured follicle syndrome, then I would also do a dual trigger. Maybe one last controversial issue, maybe 2. It is an issue of gender selection. Do you do that in India at the embryo level? And then the other one, which has actually, we are still grappling with it in this part of the world, the issue of surrogacy, foreign surrogacy. Do you mind commenting on those 2 then?
Okay, so both are very much controversial topic in India. The first is sex selection. It is very much banned. It is legally, it is criminal offense. It is a criminal offense for doctor also, as well as for the patients too. So that is out of the question. Sex selection is not done by any mean, either prenatal or postnatal. It is banned. About surrogacy, before the Surrogacy Regulation Act came, a lot of international patients were coming as, I mean, for surrogate mother, and they used to do surrogacy and they were doing, but a lot of issues have started. Government has faced a lot of issues with that. There were few cases which really made them to come up with a surrogacy bill, and now it says that no foreign national can opt for surrogacy in India. Only Indian nationals are allowed to do surrogacy in India. That's it. That too with a lot of procedures. The doctor only, if I am a gynecologist, I cannot only decide this patient is for the surrogacy. I have to send my file, all my findings to the board, which is there by done by, I mean, formed by the government, and they will sit and they will approve that yes, this patient really needs surrogacy. Second thing, they are saying there is only altruistic surrogacy which is allowed. They are not allowing any sort of commercial interest in that. So again, that is very much landmark decision to remove commercial aspect from the surrogacy. So basically, surrogate mothers are usually from the family of the patients, those who are really genuine. So all the unwanted, I mean, rather I would say those which were not so necessary as a treatment option, that all have stopped. So surrogacy is again, under strict supervision.
Okay, fantastic. Thank you for that. We have learned today. We have sat at the feet of a master and we have learned. We have learned about the oocyte, which is a very, very important, the quality of the oocyte, the mitochondria, how they affect fertility. Talked about sperm all the way to the lab, what kind of incubators are needed, and so on. We have talked about chances of implantation depending on the quality of the oocyte and also subsequently the quality of the embryos that come from them. PGTA, something which is new in a way in this part of the world, but which we also use as a tool to help our patients, to succeed. We are aware that you do some training, as you can see in the pictures there. If anybody would like to sort of have a contact with you, I think we can do that through John, who is here with us, and we can sort of connect you to them. I want to thank COGS. Oh, there is a QR code there. I want to thank COGS, people who are behind the scene who have made this possible. There is Ian, there's Maulida, and the office, and the other guys in the office. Thank you very much for making this successful. Thank you, John, who has been in my office very early in the morning to make sure that we have put this together. Thank you, Harleys, for coming on board and for bringing this very interesting and very insightful and very timely subject to us. Thank you, the bosses of Harleys, Dr. Aida and the other gentlemen. Thank you, everybody. You should clap for yourselves because you've taken time off from your very, very busy schedules to come and sit here and listen to this topic. Thank you for the questions and for the comments and for your answers to the questions that were presented. Of course, in an evening, we cannot be able to exhaust this topic. I'm looking forward to more interactions with you, Dr. Kapedia, and also to work together with Harleys to continue educating and enlightening our colleagues. Because at the end of the day, we are all happy when our patients, when our couples who come to us have been struggling for some time and they go home, expectant, and at the end of it, deliver and start a family life. We are very grateful and we are humbled for you bringing us this knowledge, and we thank you very much. So thank you very much, ladies and gentlemen. A very good night to all of you, and good night. Till the next time. Bye-bye.
Thank you, guys. And let me compliment Doctor for being such a great moderator. Let me tell you and compliment again that till date, you are one of the best moderators I have, and it was a very good interactive session with you. I really thank you. Thanks all the participants, and I thank Mayor specifically. I cannot name the whole team because I barely, know these guys, but they did a fantastic job. So thank you again from bottom of my heart. Thank you.
Thank you. Thank you very much, and good night.
And good night.
Bye-bye.